in the immunotherapy work group. We have Graham from HalioDx, who's going to provide some great updates about the Immunoscore, really the advancements in their work with Immunoscore as leaders in the field. And I know that I think it was last year at ASCO, we had a chance for Jerome Gallon and his team. And I think, Graham, were you working with Jerome at the time?
Not at the time, no.
Not at the time, but we had a really sensational discussion about the advancements with Immunoscore, and I think at that time exploring some of the clinical trial work, and then really what was opening up within the U.S. And so we're really excited to have Graham give an update in a lot of the work with Halio and looking at the diagnostics. So super glad about that. Happy for the opportunity. I think Graham will continue to also, we are going to be recording today, everybody. So if for some reason you have to miss out, I know several, I think there were 10 to 15 folks who had provided input that they weren't joining today, might be viewing it another time. But if you'd like the information from today, we will be hosting it on the Fight CRC website and sending people there. I think we're probably expecting anywhere from 20 to 25 people on. I think we already have about 16 on. So far. So I just want to say we're going to actually spend most of our time really delving into the presentation and the updates on the science with Halio leading the way, having some open discussion about possible collaborations, next steps. And then Graham, when we get to that point, we'll go ahead and unmute everyone to open up the lines for discussion. And just a quick reminder, everybody, that on the bottom of your screen, if you toggle down, there is actually a chat, and Reese just put a message. So if you see a question or want to pose a question real time, Graham, are you okay if we kind of slow you down and just have you answer questions real time as well?
Please. Yep.
Okay, perfect.
That sounds great.
So we're going to go ahead and start the discussion today, and super excited about where we're moving. Just as a quick heads up, I think many of you have been engaged in the immunotherapy work group or one of the work groups that Fight CRC has been convening. We're really excited from the last call and the last meeting at ASCO, where we were talking more about the clinical trial finder and then how to really advance the work in the immunotherapy atmosphere. So I think this is a really nice entree into this work. We did have a quick check-in call with IBM Watson today that was promising about looking at where they're moving in terms of support of the trial finder and looking at possible collaborations. So just building off of our work at ASCO last time with Halio presenting with Graham's team, and then also the last updates, I think even continuing to convene as a group and hosting the discussions and thinking about how we can best support patients is really something that's been very beneficial. So thank all of you in advance for continuing to work with us. So Graham, I'm going to go ahead and turn it over to you. I think you have full access to advance your own slides. And a quick reminder, everybody, if you want to go ahead and write who you are so we can get a role list today in that chat feature. And if you have questions, go ahead and key those in real time. Reese, are there anything else before we turn it over to Graham?
I would just say if you aren't on mute, please put yourself on mute unless you have a question, just to avoid background noise.
Okay, very great. And so Graham, I'll turn it over to you now.
Thank you so much, Andy and Reese, for your coordination here. And thank you all for joining us. As I mentioned, I've been with HalioDx for about 4 or 5 months now, but I've probably heard more about last year's peri-ASCO Fight CRC discussion more than any other feedback mechanism that internally that we've experienced. So obviously this is a very critical forum for feedback, and we really value your perceptions and your brainstorming. So we're looking forward to that today. So what, the charge I have is to sort of review a little bit about the Immunoscore biomarker and its current clinical utility, and it's, as you know, it was launched here in the United States back in January of this year. It's sort of a newer tool that can be helpful for clinical decision making with stage 2 and stage 3 colorectal cancer patients. And moving forward, we would, there were some new data that were presented at ASCO, so I wanted to review those data with you, as well as thinking in the future about additional directions for clinical trial opportunities and furthering the levels of evidence as well as the indications for using the Immunoscore biomarker as a readout for patients' immune activation status. So I am Graham Poage. I am the medical affairs lead here in the United States. I have with us, I believe on the phone orally, Cato, who is in Marseille, France, where our home office is based. She is a director of clinical development, so she's exactly the person we want to be part of this conversation, to directly hear from you where you think the strongest need is in terms of taking the biomarker in a new direction. So let me advance the slides. So as I mentioned, I'd like to quickly review some of the design of the Immunoscore assay, the unmet needs, the evidence supporting its current clinical utility, a discussion of where this is being used clinically, as well as your feedback on where you think it should be used. The future of clinical trial opportunities is where we'll end the discussion. So I'll start by talking a little bit about localized colon cancer. The medical decisions, as many of you know, are for stage 2 are slightly different than stage 3, but they generally revolve around the application of adjuvant chemotherapy, 5-FU-based or capecitabine plus or minus oxaliplatin. The decision to or to not use apply adjuvant chemotherapy in the stage 2 setting is the typical medical decision. For stage 3, it's a little bit different based on a higher risk of relapse for stage 3 patients. Generally, most patients are treated with adjuvant chemotherapy. The question, as has been explored recently, is, can we reduce or de-escalate therapy to reduce the risk of serious toxicities from 6 months to 3 months in select patients? So the gold standard for risk assessment to guide medical decision-making is currently clinical pathologic factors and typically the AJCC T&M staging. As you see on the left side of your screen, can you see my cursor, by the way? If somebody just nod yes if you can see my cursor. Okay, great. So disease-free, 5-year disease-free survival is very, non-linear when it comes to staging. So stage 2A patients, have a similar 5-year disease survival as stage 3A patients. These are real-world data now coming from Gunderson et al. From published in JCO 2017 from SEER. So you can see that stage 2C patients, on the other side, have a much worse prognosis than stage 3A and 3B patients. So that tells us something about the factors that we use to guide decision-making are not optimal, and there is a need to improve risk assessment to optimize adjuvant chemotherapy decision-making, because the reality for many patients is they end up getting treated when they actually don't need chemotherapy. All patients typically need surgery, of course, but for the chemotherapy decision, many are overtreated, while some, unfortunately, are not appropriately selected or self-select to not receive chemotherapy or shorter durations of therapy. So the Immunoscore was a tool that was designed specifically to address this question by understanding the role of the immune system in the individual patient's body and at the site of the tumor. It's a completely new assessment and is different than many other typical risk assessment tools based on gene expression or other types of tumor-specific factors. This takes into account the patient's immune environment, as well as the activity at the site of the tumor and the core in the invasive margin. So this is done using an automated digital pathology-based immunohistochemical analysis of tumor T lymphocyte infiltration. It is accurate and reproducible, as it is using automated technology and takes much of the human element as is observed with typical pathological analysis, which looks at smaller numbers of data points. The IHC automated digital pathology takes in millions of data points per patient. So that is a significant benefit of using this type of methodology. The clinical validation program has now analyzed over 6,000 patients to determine analytical validity, clinical validity, and now clinical utility. So one slide going a little bit more in depth in how this is done. First of all, patient tissues that are paraffin embedded are cut, and the tissue architecture is delineated using H&E staining. The core tumor is digitally separated from the invasive margin and also the stromal and healthy tissue to determine the regions of where the tissue is to be analyzed in terms of the immune cell infiltration. So next, immunohistochemically, the tissues are stained for two markers, CD3 positivity and CD8 positivity. These are outputs of immune cell infiltration into the tumor, and we look at those density plots in correlation to where at the site of the tumor or the invasive margin those cells are to determine whether or not they're actually just at the gate of the tumor or they pass through the gate and get into the center core of the tumor. These attributes are combined and an Immunoscore result is calculated ranging from IS0, which is the least infiltrated type of tumor, and that's correlated with the highest risk of relapse for the individual patient, all the way up to Immunoscore 4, which has the most infiltrated T lymphocyte infiltrated tumor, and that's associated with the lowest risk of relapse. It's a standardized, objective, and quantitative method for measuring T lymphocyte infiltration into the tumor. So before I move on, are there any questions here? I'm going to pull up my chat. Okay. Somebody raise your hand if you want to ask some questions here.
And Graham,
right.
we'll just give 1 second that if anyone wants to come off mute, we'll give about 10 seconds to let you come off mute to ask a question real time.
Sure.
Well, 7, 6, 5, 4, 3. Okay, and you're good.
Perfect. So I'd like to talk a little bit about the current evidence supporting the assay and a little bit about discovery and development. So the Immunoscore was discovered back in 2006 by Jerome and colleagues, Jerome Galland and colleagues in France at INSERM. It was found that the type and density and location of the immune cells within colon cancer patients' tumors better correlated with outcomes than did typical clinical pathologic factors. So I don't mean to, I show you a lot of data here. I don't mean for you to read it all. The idea is that there's an evolution over time of more and more patients, stage 1 to 4 colon cancer patients that have been analyzed using the Immunoscore. And in each of these studies, the significant advantage, prognostic advantage of using the Immunoscore assay had been that it better refines risk than, say, T&M staging or MSI status for individual patients' grade, typical clinical pathologic factors. So once the assay had been discovered and developed, it was analyzed to turn to the analysis turned to clinical validation, and there are 3 large cohorts that were involved in the pivotal validation trials, right? So the first is the SITC trial, which you guys analyzed the last Fight CRC meeting. It was published in The Lancet in 2018 and included stage 1 to 3 patients, with a significant proportion of those being stage 2 patients. So it's really the pivotal validation trial for stage 2 patients. In the stage 3 setting, there were 2 prospectively defined and retrospectively analyzed samples from randomized control trials. The first being a publication or a poster presented by Frank Sinekrup at ASCO GI in 2018, and the second being the new ASCO data presented by Frank Poage involving stage 3 patients, the validation of the prognostic value of the Immunoscore, as well as in the IDEA study, the French arm of the IDEA study, validation of the benefit for Immunoscore to predict which patients actually benefit from longer durations of adjuvant chemotherapy in the stage 3 setting. So moving to the Lancet study, just a quick overview to remind you, this was a large international validation study. It was led by the Society for Immunotherapy of Cancer. The statistical analysis was performed in an independent setting at the Mayo Clinic. It involved over 3,500 patients in total with stage 1 to 3 cancers, a monumental effort. It was validated that the Immunoscore helped to identify patients at good risk and had a worse survival profile that was provided independent and complementary information to the typical clinical pathologic factors that are used. It was validated as a dichotomous biomarker, so low or high Immunoscore. It was also validated as across as a continuous validation, as well as the individual Immunoscore 0, 1, 2, 3, 4. So shown here is just a summary of this, showing that when the Immunoscore is included in a multivariable model, 47% of the variability in patient prognosis could be explained by the Immunoscore, suggesting that incorporation of this tool significantly benefits the decision, both the risk assessment decision and also how to guide treatment based on a risk-based estimation. So thinking about the stage 3 setting now, the North Central Clinical Trials Group N0147 trial was the first pivotal validation study in this group. Stage 3 patients involved over 600 patients that were in the 6-month FOLFOX arm of the trial. And the Immunoscore was indeed helpful in identifying patients who either had a good survival profile, so a 92% disease-free survival over 3 years, and separating a patient population who had a poorer prognosis, so 78% disease-free survival profile within that first 3 years. This was true in, across clinical risk classifications as well as molecular classifications, such as within the MSI or MSI high or mismatch repair proficient subsets. Now, moving to the data that were presented at ASCO this past June, I wanted to share with you some exciting validation work, the biomarker analysis of the IDEA, the French arm of the IDEA trial, which is the multinational trial that investigated the duration of adjuvant chemotherapy. The idea of the IDEA study, of course, is to ask the question of whether or not we could decrease the toxicities associated with adjuvant chemotherapy by decreasing the duration of treatment. And so this provided the ideal setting to analyze both the prognostic ability of the Immunoscore biomarker assay as well as the predictive. So can the Immunoscore biomarker identify good risk and poor risk subgroups? Risk is nice. It's really important for classification and deciding, a myriad of factors when it comes to management of stage 3 colon cancers. But what we really want to know, of course, is what can we do about it? So can the application of a specific treatment or a specific duration of treatment based on a biomarker actually influence patient outcomes in a positive way? So that was the idea for the primary endpoint of the biomarker analysis of this trial, was to validate that in Immunoscore low, so the least infiltrated patient tumors, that we can identify those with a higher risk of relapse or death versus patients who had a high Immunoscore classification and they had a better survival profile over 3 years. There were 1,322 patients in the IDEA French trial that had available tissue. At the end of the day, 1,062 of those patients were able to be identified with an Immunoscore result. And of those patients, 973 were treated with FOLFOX. The remaining 8% of patients were treated with CAPOX. So the CAPOX was a minority arm, consistent with the U.S. experience. I think fewer patients are treated with CAPOX here than in other places across the world. So the Immunoscore indeed met its primary objective, was able to separate out different risk groups, both as a dichotomous variable as well as a continuous variable. As I mentioned, prognosis is critical, and also the benefits of predictive aspect of the biomarker is also essential for medical decision making. So in the pre-specified secondary endpoint, the Immunoscore was analyzed tested as a predictive biomarker. So what was found and presented by the authors was that the Immunoscore high patients, the patients who are most highly infiltrated, were the patients who benefited from significantly longer durations of adjuvant FOLFOX treated. So if you look in the Kaplan-Meier plot on the left, patients who are classified as Immunoscore high derive significant benefit, over 12% absolute benefit, from the longer duration, 6 months of FOLFOX, compared to patients who are treated with 3 months of FOLFOX. On the opposite side, Immunoscore low patients, so weakly infiltrated, T lymphocyte infiltrated tumors, these patients had a survival profile that was similar regardless of the duration of adjuvant FOLFOX, suggesting little to no benefit in this population. So only patients with Immunoscore high benefited from 6 months of adjuvant treatment. And if when the typical statistical methodology, the interaction term, biomarker by treatment interaction term, was statistically significant according to the criteria laid out in the statistical analysis plan. You know, in a subset analysis, obviously the typical paradigm for risk assessment based on the guidelines is to look across low risk versus high risk tumors, stage 3 tumors. So this in the subset analysis where clinical risk was defined as T1 to T3 and 1 patients, as well as high-risk tumors, T4 and 2 patients. There was consistent evidence that the Immunoscore high group were the ones that benefited significantly from longer durations, or 6 months of adjuvant therapy, whereas patients who are classified as Immunoscore low did not significantly benefit from longer durations. And I should mention that about half of patients are classified as Immunoscore high in this study, and half of patients are Immunoscore low. So there is a significant population using this tool that could benefit from knowing what their immunological profile at the site of the tumor is. I'll stop here for a second and see if anyone has any questions about these new data.
This is Al Benson. I'm sorry if I missed it. What did you say about CAPOX?
Oh, a minority of patients in the French IDEA study were actually treated with CAPOX.
That's an important issue now. If there is a difference in terms of people get CAPOX.
Yes, absolutely. Thank you.
So do you have plans to look at that in one of the studies that did have CAPOX patients?
That is our objective. Yes, is to validate this in a CAPOX population. The bar is high, of course, because particularly in the low risk T1 to 3N1 patients, the value of longer durations of CAPOX in the parent trial, the absolute benefit is exceedingly small, if any. So, you know, you using a biomarker to select patients, it's really hard to take no benefit and make some benefit out of it. A biomarker it's much more useful, I think, in the setting to take a small benefit and amplify it into a large benefit, as shown with FOLFOX treated patients. But yes, this is an important clinical question that we hope to answer with further validation work. Yeah.
Because I would say.
Go ahead.
Well, I would say that, you know, we have a number of prognostic markers, but what's really important is the predictability of treatment outcome. And so, you know, currently with high risk, the current perspective is just based on staging that, you know, 6 months of FOLFOX, if you're going to use FOLFOX for sure, is important. But I guess for further validation with this high-risk group, if Immunoscore can segregate out people who can truly get 3 months of therapy, that would be important, but also very important with CAPOX to see if CAPOX might be a superior approach for this group. But, you know, the utilization of Immunoscore will be dependent mostly on predictive factors, if it can really segregate out patients who can have 3 months of therapy, or importantly, those who would not need adjuvant therapy at all. And we know there are stage 3 patients where that is true. They probably don't benefit from adjuvant therapy.
Yes, absolutely. That's a perfect segue into my next slide, actually. I wanted to share with you this new information that was just presented by Jerome Galong this past 2 weeks ago, I think, at ESMO GI. So the Society for Immunotherapy of Cancer, the Lancet publication, I mentioned before that this was really especially a validation for stage 2 patients, but included stage 1 to 3 patients. So in this analysis, just given your unmet need that you described for stage 3 patients, that there are some patients who don't benefit from adjuvant chemotherapy. The idea of this retrospective analysis is to look specifically at those stage 3 colon cancer treated patients who were or were not treated with chemotherapy in a retrospective fashion, and look at the disease-free survival profile according to the Immunoscore. So in patients where the question may be treatment or not for stage 3, can the Immunoscore predict who would benefit? And I think when you combine these data with the IDEA data, there's consistent evidence that the Immunoscore high patients are the ones who are significantly benefiting from either longer durations of therapy, and in this case, therapy at all. So yes, no to chemotherapy. So if you look in the left panel, patients classified as a high Immunoscore significantly benefited in terms of time to recurrence, in this case, from adjuvant chemotherapy, versus patients on the right side who were classified with a low amount of tumor lymphocyte or T lymphocyte infiltration, did not significantly benefit from the use of adjuvant chemotherapy. So a slightly different setting, one being the IDEA trial and the other being the retrospective multinational trial, but still consistent evidence. So I hope this addresses some of that unmet need, and certainly this is an area where future research is certainly needed, and further validation will be critical in the future.
This is Al again. Did you overlay these curves with TNM staging risk? So just like the IDEA trial did, because I think it would be helpful to see how these compare if you incorporate the TNM stage for both high and low.
Absolutely. And that is part of this is being written for publication right now. I anticipate that the full subset analyses will be in the publication. But I don't have those data here to answer your question directly. Thank you. Any other questions before we move to the next section? Okay. As we alluded to, there's current clinical utility. We've developed some clinical experience here in the U.S. and there are data to support the current clinical utility. We're interested in hearing a little bit more about your feedback on these data and these paradigms. So let's jump into current use of the Immunoscore biomarker for decision-making and risk stratification in stage 2 and 3. This is jumping back now to the Lancet publication. What we know is that the Immunoscore is a validated tool for separating prognostic risk, patients into high risk versus low risk groups. In particular, an abstract presented by Jerome Galam at ASCO GI this year showed that when we look specifically in the high clinical risk patients, so they have at least one high risk feature, these are untreated patients, 1,130, that the Immunoscore biomarker significantly identifies proportion, actually 70% of clinical high risk patients that actually have a survival profile that is very similar to low-risk patients, suggesting that any potential benefit from adjuvant chemotherapy in these patients may be unlikely to outweigh the risks of that adjuvant therapy. So this could be as a selective tool to pick clinically high-risk patients and potentially de-escalate in terms of adjuvant therapy. Not, of course, not in terms of surgery, but in terms of adjuvant chemotherapy. And then we also have restratification, risk stratification of MSI groups based on the Immunoscore status of the patient and of the immune profile. So in terms of where does this fit in with clinical risk assessment, typically we're thinking about high-risk patients who would be considered for adjuvant chemotherapy. And as I mentioned, those patients who have an Immunoscore high, so a highly infiltrated tumor, these patients could be reclassified as low risk, potentially just being managed surgically, versus higher risk patients, in terms of molecularly, as identified by the Immunoscore low group. These patients typically might be considered low risk because they lack clinical risk features, but these patients indeed have a higher risk of relapse and thus might be managed as a high-risk patient. And that really depends on the shared decision between the oncologist and the patient in terms of what to do about that risk. But that's a little bit beyond the scope of what the Immunoscore currently is designed to do. We have some data in these types of patients, or some studies ongoing in these types of patients in France to determine whether or not, for instance, an active surveillance strategy might be beneficial, but currently we're waiting to see those data. Moving to stage 3 clinical utility, we now have 2 prospectively defined retrospective analyses from randomized control trials, being the N0147 and the IDEA cohort in over 1,500 patients, validating the prognostic ability assay in terms of being able to identify poor and better risk prognostic groups. And normally we don't, the cross trials comparison is frowned upon, but I really wanted to show you these extremely consistent data between the 2 studies, in this case, the 6-month FOLFOX arms of each of these studies. Patients who are classified as highly infiltrated, so Immunoscore high, had a 92% 3-year disease-free survival in both studies, whereas patients classified as a low Immunoscore had a very consistent 77 to 78% 3-year disease-free survival. So, as we mentioned, prognosis is very important. We have a lot of tools for prognosis. Immunoscore can help refine a lot of those traditional tools, but we also need that predictive data. And so we now have our first predictive data in the IDEA French cohort, showing that patients who are classified as Immunoscore high significantly benefit from longer durations of therapy. Now, where does this fit within clinical risk assessment? After the IDEA trial, reported out at ASCO 2017, the sort of consensus that came out of it was that T and N status were really the gold standard for identifying patient risk, identify patients at risk of relapse, and therapeutic decisions based on those risk classifications. What was found in this IDEA French trial, and will be validated in additional, hopefully additional IDEA trials across the world, is that Immunoscore can help refine these risk categories as well. So, for instance, the low risk T1 to T3 N1 tumors, who would typically be considered or could possibly considered for de-escalation of FOLFOX adjuvant therapy. CAPOX is a slightly different question, but again, we didn't have significant numbers to power that study in the French trial, but we're looking for more cohorts to validate that. The Immunoscore high patients would be the ones who actually benefit from the longer durations of adjuvant therapy. So a selected tool to find about half of low-risk patients who might benefit from longer durations, whereas the Immunoscore low patients, regardless of risk group, do not significantly benefit from the longer duration of FOLFOX. So I'll stop there for a moment. If you have questions or would like to provide some feedback on these slides, we would be very happy to hear your thoughts.
So, Graham, while everyone is maybe collecting thoughts and giving people a minute to come off mute, and we'll give that time, let me ask you for the information and the data that you presented thus far, and I think where you are all moving, what are your questions for the group? I think that's one of the things that I think in our last ASCO meeting, there were some really salient questions. Where are you right now in terms of needing and wanting feedback sitting on your side at Halio?
Well, yes, thank you. That's a great question. And I guess to this last, we have questions on future clinical trials, of course, but in terms of the current clinical utility, for this group of very knowledgeable individuals, I guess we would ask, where is the clinical need the greatest? Is one, stage 2 high risk, stage 3, chemotherapy, yes, no, or this, how important is the question of 3 versus 6 months in this group's opinion? And, what additional data? I think we have some thoughts from Dr. Benson of what's needed next. But what additional data and what additional cohorts could we analyze with the Immunoscore biomarker to really bring this fully you know, in the crosshairs of medical management for these patients.
Okay, great. I think that's super helpful as well. So I know that Nick Petrelli, Ian Tomlinson, and I think Noel Miranda, as well as Minye and Song, I know are a couple of people that I see and recognize names. But I'm just, I think maybe to get us started, thanks Al so much for already interjecting some questions. But I think of the folks that I mentioned that I know that are doing work clinically as well as have some specifics. If you can, you know, probably either react to Graham's question or ask any questions related to anything you've seen so far, we'll go ahead and open up the line. Ian, is there anything specifically coming up for you right now? I think I saw you come off mute.
Yeah, I'm in a slightly difficult place for asking too many questions. I'm interested how robust some of the data are in terms of the cut points you use. So in one of the slides near the end, for example, you had a sort of, I think it's 25 to 100% versus 0 to 10% set of comparisons. What happens if you consistently cut at the median, for example?
So, okay, so I guess I hope I heard your question correctly in terms of the cut points for the Immunoscore. So we have those. Maybe I'll go back to sort of more to the beginning of the presentation. So we have these Immunoscore groups based on the cut points, right? As you mentioned, Immunoscore 0, 1, 2, 3, 4. I don't have a slide showing the exact cut points for each of those classifications, but in the validation studies, as I mentioned, you know, the individual dichotomous cut points, which, you know, Immunoscore low versus Immunoscore high is considered 0 to 1. Those cut points are quite variable. You know, you could consider a cut point at Immunoscore 2. What was found over the course of the discovery and the development was that the Immunoscore cut point of 1 is optimal for a dichotomous variable, but in the validation studies, it was shown that as a continuous variable, the Immunoscore was also prognostic. So in terms of prognostication for patients, it doesn't matter where you are. You know, the highest risk group of patients is the least infiltrated, going up all the way continuously to the most highly infiltrated. That's the lowest risk of relapse. So it's you know, the assay is fairly tolerant to changing the cut point, but you know, we would shy away from changing the cut point at this point in time, because the pivotal validation studies have now been conducted and have determined that the future for the assay essentially is that, you know, that cut point is prognostically valid. In terms of prediction, there's also a continuous predictive value that is underlying the ability to pick patients who significantly benefit from longer durations of adjuvant chemotherapy in the stage 3 setting. And those data will also be presented in the manuscript, which is very close to being submitted for publication. So I don't have more details on that right now. That manuscript is in, you know, the investigators' hands and not HalioDx. We conduct the biomarker analysis, but we're not in charge of the paper or the statistical analysis.
Okay, thank you.
You're welcome.
Okay, great. And I know that we have, I'm just looking also just to make sure I have some of the folks that have introduced. I think we have Matt Young, Anil, and Holly also from the NCI. So from our NCI colleagues, and based on what's been presented, and I think to Graham's questions, is there anything specifically coming up for you all in relation to, I think, the clinical trials work, and then I think has some of the clinical implication? NCI folks, anything that you would like to comment on? And I don't know if anybody can come off mute. And I'd open it up to any other specific questions or comments too.
It is a bit of a challenge trying to find additional validation cohorts, randomized control trials, which is part of the reason that the international SITC study was conducted, is because the absolute benefits of adjuvant chemotherapy in the stage 2 setting are minimal. Even high risk stage 2 is a small % absolute benefit. A lot of patients have to get treated to actually see significant patients who benefit from that therapy. And the stage 3 setting is sort of similar, especially after more than 12,000 patients in the IDEA trial. We didn't get a clear, definitive answer for whom longer durations or shorter durations are acceptable, with the exception of certain subpopulations in secondary analysis that really need to be further validated. So we have the same challenge in identifying those populations that we can further validate this biomarker in.
Hi, this is Matt Young at the NCI. I think what I'm hearing in our list of participants today is mostly from the prevention side. So while it's great to hear these studies, and it's more important to hear about large cohorts that are available, we probably don't have a lot at this time to add for these ongoing studies. It's important as we move forward to know where everything is, and will help when the time comes to put in for funding or additional funding, to know that we can work across different consortia.
Thank you for the feedback. Yeah, I'm a preventionist myself, going back to breast cancer and carcinogenesis world. So I'm very much in alignment of finding attributes of patients early to help prevent either primary or secondary prevention of disease burden. Absolutely.
And in the spirit of continuing to call on people, which I know everyone really loves, by the way, I hate that when people do it to me, but I think there are also a couple of patient advocates who are joining today. So Lyra Chitwood, Kimberly Bush. And so Lyra and Kim, if you have any specific questions, I think, and any perspective from the patient voice and community, I'd also open up the opportunity for please to go ahead and in the chat, or even coming off mute if there's anything that's coming up for you ladies. And I don't know if there's an additional couple of research advocates on as well that I might have missed. Okay.
All right. Great. So we will move on now to our last topic, which are future indications for the biomarker and future clinical trial opportunities. I'll describe briefly one other poster. We talk about CRC, right, colorectal cancer, and most of the data that I just showed you was in colon cancer. So we are also examining the ability of the Immunoscore to both prognose and predict various medical intervention and patient survival in rectal cancer. So these data were presented at this past ASCO by LCC and colleagues, examining rectal cancer patients specifically to ask the question, can Immunoscore predict which patients benefit from neoadjuvant chemoradiotherapy, and also in those patients who have been treated with neoadjuvant therapy, can the Immunoscore identify which patients can potentially safely be considered for a watch and wait strategy, which is now an evolution and a de-escalation, because surgery after therapy is associated with significant comorbidity in the rectal space. So the Immunoscore, because patients are treated in the neoadjuvant setting rather than a typical colonic resection or surgical resection. These patients really only have a biopsy. So the Immunoscore had to be adapted to a biopsy source material in those patients with locally advanced rectal cancer. And specifically going to the middle survival plot here, in the 73 patients who were considered for watch and wait therapies, importantly, there was not a single patient with evidence of relapse in the Immunoscore high patients, again suggesting that having this active or potentially activated immune system at the site of the tumor really has a difference in terms of patient prognosis. And we don't show it here, but the Immunoscore also helped to predict which patients benefited from neoadjuvant chemoradiation in terms of pathologic complete responses and endpoints. And then when incorporated into multivariable models, the Immunoscore provided independent and significant prognostic information in addition to the clinical pathologic factors that are typically used to help determine which patients both should be escalated to surgical treatment after neoadjuvant radiotherapy, as well as identifying which patients could safely be applied to the watch and wait strategy. So another area certainly of interest to this group is how can the Immunoscore be applied in the setting of immuno-oncology, as we say, with immune checkpoint inhibitor therapies. Can the Immunoscore identify patients who might benefit from these therapies, particularly among microsatellite stable patients? So stage 4 colon cancers who are MSI high potentially could be treated with immune checkpoint inhibitor therapy already. The question is, can we identify other patients who are not marked by a microsatellite unstable phenotype that might also benefit from these therapies? So the rationale, the early rationale from this idea comes from the SITC Lancet study again, identifying that the Immunoscore the patients with Immunoscore or highly infiltrated tumors have prolonged survival irrespective of their microsatellite status. So MSI high patients and microsatellite stable patients that are classified as a high level, high infiltrated T lymphocyte infiltration in their tumors had a similar survival profile, whereas patients who had low infiltration, regardless of whether they're MSS, microsatellite stable, or MSI high, also had a similar profile. So indicating that potentially the Immunoscore could be used to reclassify in terms of risk a fairly significant proportion of patients, about 1/5 of patients who are Immunoscore low and MSI high have a poor survival profile. So they may not, they may be considered differently than the typical MSI high patient. And MSS patients, 15% of MSS patients that are classified in Immunoscore high have a much better survival profile. So, where does this apply to immune checkpoint inhibitor therapy? A recent abstract presented by Jerome Galan and colleagues at ESMO Asia examined from that Lancet 2018 study the patients who recurred. So thinking about stage 4 patients who had their tumors analyzed by Immunoscore and then recurred, what were the distributions of the Immunoscore in the setting? So in this, in the overall study, 1,500 patients, almost 1,600 patients went stage 1 to 3 who had an MSI status and an Immunoscore. 318 of these patients experienced a relapse. 11% of these were MSI high, so potentially those patients could be considered for treatment with immune checkpoint inhibitor therapy. The question is, what to do about the majority of patients, 89% of them who are MSS, microsatellite stable, in their tumors. So the distribution of immunoscores within these MSS patients are shown in this pie chart on the right, with the idea is that can Immunoscore identify an additional proportion of MSS patients who might be considered for immune checkpoint inhibitor therapy because their local immune architecture is present and potentially activated at the site of the tumor. And what was found was that 12% of these patients had a high degree of immune cell infiltration, suggesting that use of Immunoscore, identifying Immunoscore high infiltrated patients with MSI positive or MSI high patients could extend the reach of clinical trials from 11% in this analysis to 22%, the patients who would be eligible to receive immune checkpoint inhibitor therapy in the setting of potential clinical trials. So this is these data are very interesting, and we hope to expand further based on this. If if you want to put this diagrammatically, I think this was nicely presented by Sveen Scott Kopetz and colleagues in a recent Nature Reviews Clinical Oncology article, showing that in immunologically hot tumors, there are a number of markers to identify these patients who might respond to immune checkpoint inhibitors, including MSI, as we've discussed, potential molecular mutations in POLE, as well as TMB, which is a reflection of how mutationally active the tumor is, with the association that more mutationally active tumors create neoantigens, which are then substrates for the immune system. So of course that depends on having the immune system there, and Immunoscore is the way that you can measure that presence of the Immunoscore in the case of neoantigens. So I think Immunoscore can help refine which patients might be candidates for immunotherapy trials. So this is an active area that we're involved in, and Orally and myself, as well as others from HalioDx, would be very interested in hearing your thoughts on which types of studies and additional areas of opportunities for research in this setting would be beneficial.
All right, awesome. So Graham, thank you so much for this work. I think we're going to go ahead and just, in the few minutes we have remaining, I know that we got a couple really good discussion points from Al earlier. And is Al still on right now? I don't know if he was able to stay on recently.
Yeah, I'm here.
Great. Al, what's coming up for you now? I know that you've had a lot of interest in work in this connection. As we're closing out, I'd love to get some feedback from you.
Well, I think what's reflected here, if there is an MSS subpopulation that will respond to immunotherapy, with the CMS subtyping, there is the implication that there may be MSS patients who will respond to immunotherapy. So this is an area, if Immunoscore can accurately reflect that would be important to know. Also for there's concern that there's an MSI subpopulation that may respond less to immunotherapy, and we need to identify that subgroup and look for new strategies. And then, as discussed before, as a predictor, whether with the surgical resected patients, if there are subsets that do so well, those would be important to identify to avoid chemotherapy, particularly stage 3, and then also to refine the group of patients who may do just as well based on Immunoscore risk with 3 months of therapy versus 6. And that's important because it can reduce potential toxicity. But there, you know, it really boils down to how much you can use Immunoscore reliably as a predictive factor, whether it's benefit from immunotherapy or selecting patients where we need totally different strategies because they're going to do poorly based on standard therapy, and selecting those who don't need therapy at all. I think those are kind of key areas where if we have good confidence based on Immunoscore, that would be helpful. And, you know, the field is clearly evolving with technology. So how does Immunoscore keep up with evolving technology in terms of selecting patients and what we're learning from immunotherapy studies?
Mm-hmm. Yeah, that's great feedback. Thank you. Yeah, the prediction is obviously key, and we're working towards that effort on many fronts here. So that's great feedback. Thank you.
Okay, great. So I know that we're just even a couple minutes after the time that we had set for today, but I do want to see if anyone else, Dr. Petrelli, any of the others, I think Noel Miranda, Kim, as well as Lyra and others who might not have had a chance, if there's any other final questions or thoughts.
This is Nick Petrelli. That was a great review. I really have nothing to add. That was really great.
Perfect.
Thank you, Nick.
And if there aren't any other questions, that might be a perfect place to end. So I think going ahead, I do think that we are going to open up the forum for Halio and others who do have additional opportunities for the work group and then need additional input, because this is really consistent with the immunotherapy aims and what we're really trying to do to help bolster the work in this area. So Graham, awesome to have you as a part of the team at Halio. I do know that there are several other folks, Catherine, a couple other people from Halio who have joined today. So thank you so much for all of the work and contributions. I think we'll be looking at additional research forums, in-person meetings, and additional webinar opportunities. So thank you so much for Graham. And Graham, I'll let you have the final word about any sort of next steps, how to get a hold of you. We can, again, we did have about 10 folks who asked about this recording. So I really think we're gonna go ahead and tee up those questions that you ask and what you might need feedback. So we'll try to communicate and help facilitate that discussion. But Graham, as we close out the day, anything else you'd like to share with the group or any certain next steps that you'd like to address?
No, thank you. Any further thoughts that you guys have after seeing these data, the clinical utility? Please let us know. You can go on HalioDx.com and find lots more information, all of the posters, the publications. You can send me an email. I don't have it here, but it's graham.poage@HalioDx.com. Again, here is my name, so graham.poage@HalioDx.com. Any feedback? Thank you so much from the Fight CRC organizers as well as the working group. We really appreciate you being with us, as well as those who will watch this later. Please let us know your feedback and any opportunities that you know of where the Immunoscore could help patients and providers benefit from knowing more about the immune system.
Great. Awesome. And congratulations on your great progress. All right, everybody, have a great rest of your afternoon for those on the East and noon and morning for those of us in the West. So I just realized today I had my, in my kitchen, I have my whole bar right behind me. So I just want to let you all know that there's not a liquid lunch happening shortly hereafter. Probably better stage my head in the future, but the joys of working at home. So have a great day, everybody. Thank you so much for your attention. And we'll be following up with all of you about moving this work ahead. Thank you so much, Graham.
Take care.
Bye-bye.
Thank you. Bye-bye.
Thanks, bye.
Thank you. Bye-bye. Thanks a lot. Bye-bye.